you. Welcome to our first ever webinar speaker series. PAs for Global Health is now offering this new platform. It will be a bi-monthly live webinar series free to our members. The speakers include a wide range of PA leaders, public health officers, and professional organizations. And we will be discussing a list of various topics in global medicine. Each webinar will be approved for 1 hour of Category 1 CME credit through the AAPA. It will be a live webinar series as well as recorded and released on our website. You can see our website for more information, and if you have any additional questions, you can feel free to email us at pasforglobalhealth@gmail.com. Each webinar will also be co-hosted by a different group of PA students. This webinar is co-hosted by the Yale Online PA Program students from the Global Health Student Interest Group. Today we have Dr. Oren Berkowitz speaking with us, and the Yale Online PA Program students will be introducing him. Thank you.
Thanks, Melanie. So today we have Dr. Oren Berkowitz. Dr. Berkowitz arrived at Ariel University in Israel in 2017 at the start of Israel's development of physician assistants. He was involved as a consultant about PAs with the Ministry of Health for several years, and he helps advance the new PA role through his research, education, and advocacy, including building the first Israeli PA conference in April of 2019. Dr. Berkowitz is the former director of research and co-founder of the Boston University School of Medicine Physician Assistant Program. He's an epidemiologist and a PA. Dr. Berkowitz is currently a senior lecturer, faculty member in the Department of Health Systems Management at Ariel University. He practiced for many years as a PA in neurosurgery. He is involved in global PA scholarship and is a feature editor of the Global Perspectives for the Journal of PA Education. Please join me in welcoming Dr. Berkowitz.
Hello, everyone. Thank you so much for that introduction. Thank you so much for the opportunity to speak with you and tell you the story of PA development in Israel. A lot of people ask me how I got involved in global PA development and how I ended up in my current role in Israel. So I'll go ahead and give you the brief version. I think the introduction told a good bit of my story. But basically, while I was a faculty member at Boston University, I got in touch with the Ministry of Health as they were starting to think about PAs, and came here and presented to their committee, stayed in touch with them as a consultant, and when they were trying to develop the project and thought about research, asked me to help develop that research. And serendipitously, one thing led to another. One of the people on the research project was the chair of the Department of Health Systems Management here at Ariel University in Israel. And after some contact, she recruited me and said, well, if you want to come here and move here full-time and work on this project with us full-time, I have a faculty position for you. And so that's how I ended up bringing my family to Israel back in 2017. And it's been exciting. It's been quite the ride. I have more than one white hair to show for it. But I will let you know how things have been going and let you in on some of the research insights we've been able to obtain from this early PA project. On this opening screen, you'll see, and I hope you can see my laser pointer here as I move around the PowerPoint. This is a map of Israel with the emergency departments from the first group of PAs and where they started practicing. That map actually needs to be updated. There are even more emergency departments to add now. Here you'll see, here you can see a group of 3 PAs from the north, from the Galilee Medical Center. They actually had a sponsored trip to University of Toledo Medical Center in Ohio to visit and shadow PAs there. They spent a couple of weeks in Ohio. I think 2 of them had never seen snow before in their lives. It was the month of February, and I think they had quite an adventure. Here in the lower left-hand corner is the graduation picture from the first class of PAs who graduated in 2017. And up in the left upper corner is a group of PAs at Sheba Medical Center. And if we have a little time later, I'll tell you the story of their golf cart looking device that they're standing in front of. They actually took a golf cart and rigged it to be a rapid response unit that they wheel around the whole hospital, and the PAs there are in charge of that. So let's get started with a little bit of background and context about the Israeli healthcare system in Israel. Israel is a country of about 9 million people. It is a relatively small country. The geographic size and population size of Israel is almost exactly the same as the state of New Jersey. So that should put things in perspective. The government regulates a basic health service bundle to all citizens. So all Israeli citizens get health care services. It's paid for by a tax, by a healthcare tax. And citizens actually choose one of 4 national health funds. So each of these health funds is mandated by the government to provide a basic bundle of services, but they are able to compete with each other based on the quality of those services provided, or the accessibility of those services, or the quality or type of doctors that they might have on their list. And so I think it strikes a nice balance between a socialized form of medicine with some marketplace competition that can also occur. Israel is considered to have a high-quality healthcare system overall. Israel has good primary care services, good health outcomes overall, one of the highest life expectancies in the world. It's, last I checked, 80.7 years for men and 84.6 years for women. Israel is very near the top 10 countries for life expectancy. I think last year they were at 12 or 13. So life expectancy is considered one of the main indicators for the quality of a healthcare system. But just like any healthcare system, it's not perfect, and there are gaps that need to be addressed. So just like many countries are dealing with this problem, Israel is one of them. You see my equation at the top of an aging workforce times an aging population equals not enough clinicians. So these 2 graphs are OECD ratios that show the relative ranking of economically developed countries. And the doctor ratio in Israel has dropped below the OECD average, slightly below. The OECD average is 3.3, and the doctor to population ratio in Israel is 3.1 per 1,000 people. The nursing ratio in Israel is much worse, actually, very low relative to other economically developed countries, only about 5 per 1,000 compared to the average of 9.3. So there is a significant workforce shortage in Israel. Interestingly, PAs were discussed in Israel for many years, but the idea was mostly ignored because for a long time Israel had a really high doctor to population ratio. In the fall of the Soviet Union, many Soviet Jews immigrated to Israel in a big wave, and a lot of those people were professionals, including doctors, nurses, and other healthcare professionals, and they really saturated the system. And so when people talked about developing a new healthcare provider like PAs, the Israeli health policymakers and politicians said, well, what are you talking about, PAs? We have more doctors than we know what to do with. We have so many doctors that Some of them are mopping the floors because they can't find a doctor job. So why would we ever need to develop PAs? The problem with that was the lack of foresight into the future, because just as those immigrants all came in one wave as one cohort, they're now, a few decades later, retiring and leaving the workforce as a cohort. And so the forecasted drop in workforce is exponential. And so only a few years ago did the Israeli Ministry of Health decide to take a serious look at this and begin to consider PAs as well as nurse practitioners and other healthcare providers as viable options to supplement gaps that are anticipated to come down the line. The median age of doctors, to give you a little more perspective, the median age of doctors in Israel is over 55 years old. That is considered to be an older profession. In the USA, for example, the median age of PAs is about 35 years old, and PA is considered to be a young profession in the USA. And so in Israel, we're dealing with a doctor workforce who is mostly nearing retirement within the next decade. A little more background to understand the situation in Israel that led to the creation of PAs was the problem specifically in emergency medicine services. Emergency medicine has been a particularly problematic system in Israel. There's tremendous overcrowding, long wait times. If you look at the graph on the right side, you'll see an extract from a newspaper report that showed waiting time from ED admission until a decision is made. Just a decision is made for treatment, hospitalization, discharge, and most people are waiting more than 3, 4, 5 hours to have a decision for their treatment made. And so this is something that's come onto the national radar. It's talked about in the news. It's talked about by politicians. Emergency services is a particular problem. Many EDs are operating at 150% capacity in the busy times, and some children hospitals can reach 250% capacity in the winter months. That means that people are being treated in the hallways. They can wait on a stretcher for hours, sometimes days, until a hospital bed will open up for them. Recently, I remember hearing that one hospital was so overcrowded, it actually emptied out its cafeteria and put stretchers in the cafeteria and started treating people there because they had run out of room so badly. So this is on people's mind already politically, and that helped in a way. That helped push the PA idea forward. So the Ministry of Health convened a committee back in 2013. They called it the PA Committee, and their goal was to analyze, explore, discuss, and come up with recommendations regarding the development of physician assistants. And so they looked at the workforce, they looked at the needs, they looked at the future projections, and they did in fact determine that PA was a good option, and they recommended that PAs be developed in many different specialties, not just emergency medicine, but they thought the need was there for many different specialties, and then ultimately for political reasons they recommended 3 specialties: emergency medicine, anesthesiology, and pathology. They also recommended nurse practitioners at this time for political reasons, and eventually they decided to focus on emergency medicine. So what you have to understand, though, is that was really a pragmatic approach, because they were having trouble selling the idea to any of the medical specialties. There was pushback from physicians who were concerned that this would create competition and might decrease their bargaining leverage and the value of physicians if this other entity entered the workforce. And so they utilized the significant need that existed in emergency medicine. And then they looked on the other side of the coin and they said, wait, there's also this profession of paramedics who are in need. Israel has suffered from high paramedic burnout and turnover for many years. It's been very hard to keep paramedics in the workforce. Some of the research recently has actually shown that Israel has one of the highest turnover rates in the world. It's estimated that 90% of paramedics will leave the paramedic role within 5 years. And typically they do not stay in healthcare. They leave healthcare altogether. At the same time, they figured they could leverage the problem with retention in the paramedic profession and the problem with emergency medicine services. And they said, hey, let's make a shidduch, let's make a match. Paramedics and emergency medicine go together. Let's turn these paramedics into PAs with additional education and training and put them in the EDs. And that became the easy sell politically. That became the only viable option that could hold up against political opposition. And so the emergency medicine PA was born, and the Ministry of Health launched its pilot project in 2016. But again, keep in mind that they had recommended PAs for several other specialties as well. This so far is the only one that has gotten off the ground. So how are PAs made? Basically, it is a Ministry of Health run course. It leads to a certificate. The Ministry of Health developed a curriculum in cooperation with the Israel Emergency Medicine Association, and they run a 1-year-long emergency medicine focused course. It takes about a year, probably more accurate estimate is 13 to 14 months. It kind of depends on the scheduling and how they fit in all of the curriculum. And they take experienced paramedics. It's mostly experienced paramedics. They must have a bachelor's degree at least, because again, the Ministry of Health cannot confer a degree. It's not an academic institution. They can only give a certificate. So they wanted to take people who already had an academic degree. So they took paramedics who already had a bachelor's degree at minimum, and at least 5 years or more of experience, and brought them into this course. This course was a learn as you work course, which means that, because it's still ongoing, which means that they must first get hired by an emergency room as a PA, and then register for and begin the course. And when they register for and begin the course, they work 4 days a week in the emergency department, and 1 day a week they all come back to the classroom and learn. And they spend a full 8 to 10 hour day in the classroom getting their didactic education. They receive a full salary during their education time from day one. It's considered to be a job for them. So I don't want to make any PA students in America jealous, but imagine that instead of taking out tens of thousands of dollars in student loans, you are actually being paid tens of thousands of dollars a year to go to PA school. It sounds like a pretty sweet deal if you ask me. And at the end of this 12 to 14 month course, the students must undergo a written summative exam and an OSCE exam in order to graduate. they receive a registration number with the Ministry of Health when they finish. Getting a registration number is pretty good, given that the PA role is not yet uh, um, legally ratified, and so there's no licensure available, but they get a registration number. I will add that the Ministry of Health has also installed a mechanism for American PAs to come and be PAs by joining this course. Again, it's a full-time salary from day one, and it's 4 days a week on the job, 1 day a week in the classroom. And so there have been about 5 American PAs who have gone through this course so far and are working as Israeli PAs now in Israel. And they were all pleased and satisfied with it. Most of them did not come from emergency medicine backgrounds, so they actually thought it was fun to get paid to kind of go back to school. They did allow also foreign medical school graduates to join the course, but in the first year it didn't end up panning out very well. And in the second group, I can't remember if they took foreign medical graduates who finished the course or not. But that mechanism also exists. Oh, before I move on, I'll just give you a little note on these pictures here. This was a mass casualty drill that was performed at Sheba Medical Center. And it was just so great to see how they integrated the physician assistants into the mass casualty response team. This gentleman right here, you'll see he's one of the physician assistants from the very first class, and everybody has their role written on their vest for easy recognition. And so right here, this is a nurse. You can't see her full title there, but no, sorry, I lost my pointer. And try this one more time. There we go. Nurse, and this says Rofé, which means doctor, and this one says Ozer Rofé, which means physician assistant. Okay, the PA scope of practice is vague. Basically, the Ministry of Health said that PAs could work under the supervision of an attending physician and perform any clinical duties that are delegated to them. The hope was that hospitals would play with this delegation of authorities and try and push it a little bit to see what would work out well, and to see and to customize it to their particular emergency room environment. It's been, though, a double-edged sword, because what's happened is there's a lot of heterogeneity now, a lot of differences between EDs. What a PA does in one ED does not necessarily look like what a PA does in another ED at all. And those who were opposed to PAs, which was mostly the nursing workforce, used it as a weapon and said, wait, no, you can't do that. You can't do task XYZ. I'll throw an example, a central line. You can't put in a central line because it doesn't say you can, right? So the fact that things were not outlined, tasks and role definitions were not clearly outlined, although it was meant to be useful and helpful, has often been used as a weapon where opponents say, well, if it doesn't say you can do it, then you cannot do it. Even though a PA was educated and trained to put in, for example, a central line. PAs do not have any prescriptive authorities. They cannot write prescriptions for medications or give medication orders unless it is a resuscitation situation, and then they are allowed to give orders and provide medication. Basically, what they do is the workaround that was seen in the United States before medication prescribing was legislated in the US, and the same workaround we see in many PA developing countries in Europe and in other places in the world. The PA will see a patient, come up with a treatment plan, recommend the medication, say, okay, just wait here 1 minute, let me go get you that prescription. They'll go to the doc, have the prescription either on paper already filled out or in the computer, electronic medical record already filled out, and then have the doctor sign it with their own stamp or their own electronic signature. And that's the workaround that most places use for now. PAs don't have any prescriptive authorities. So a little snapshot of the PAs in Israel. Right now, there are at least 2 PAs in almost every emergency department in the country. Again, this map needs to be updated. There's a few more been added since then. 2016 was the first cohort. 34 PAs started in 17 emergency departments. 2018 was the second cohort that brought it up to 64 PAs in 22 emergency departments. And Israel only has about 25 formal emergency departments, so 22 is almost all of them. And there are more being added for the third cohort this year in 2019. Another 30 PAs are being recruited who should graduate in 2020. So that will bring the total number of PAs up to about 100 by the end of 2020. Demographics of the first PA class from our first project, 94% were paramedics with an average of 13 years experience. So these were highly seasoned paramedics joining the first group. 88% Jewish, 94% male. There's been, since the first group, an effort to recruit more females into the PA role. It's been a challenge because the pool that we're taking from is already heavily skewed male in the paramedic world. But there's been a conscious effort, and every group seems to have a few more women. 84% born in Israel. So the average age of this first cohort was 40 years old, with a range between about 30 to 50 years old. And almost a quarter of them already had a master's degree. The bachelor's degree was required, but about a quarter of them already had a master's degree as well. So this first group especially was a very mature, highly seasoned, very well-educated group of paramedics becoming the very first PAs in Israel. We asked PAs what they spend their time on. And so I'll give you the highlights of this graph. PAs told us that basically they spend the majority of their time in the initial patient workup. They will be the first ones to go see a patient who comes in after triage and do history, do a physical exam. They will start to order tests, EKG, blood tests, chest x-ray. They will go over the patient's medical records if they have any in the system. And then they will bring all of this information together and discuss it with the attending physician. They will formulate a management plan together, and then the PA will take some responsibility in managing and implementing that plan. It might be calling the consults, it might be getting further tests done, it might be arranging an admission or a discharge, whatever the need may be. They spend less time doing procedures, so they're trained to do procedures. They know how to do it, but it's not what they spend the majority of their time on. And they spend a good amount of time actually monitoring critically ill patients and unstable patients. You will often find the PAs kind of supervising in the trauma room or in the resuscitation room any cases that came in and that are ventilated or unstable and need constant supervision. And the doctors and nurses really appreciate that because it frees them up to do other things. PAs often escort patients as well, escort them to CT or other testing or other departments in the hospital. Sometimes when I say that to an American crowd, they're surprised to hear that. They think it's demeaning, but actually in Israel, the escort role is done by doctors. Doctors are the ones who escort patients in the hospital. It's one of the requirements. And so having the PAs do that is actually having the PAs take on that doctor role, and it really frees up the docs to do more complex tasks as well. And often the PAs will tell you that they don't mind doing it because if a patient's going to crash, it's going to be on the CT table, right? Another survey research we did was to ask the emergency department physicians their thoughts about the new PAs. When we did the survey, it was during the first year of the first class of PAs, meaning that they were still, quote unquote, students. They were still in their education phase. And so we asked the doctors how helpful they would rank the PA students on a Likert scale in a number of clinical tasks. And they, on average, rank them to be helpful to very helpful in all of the survey tasks. You'll see each item explain new patient workup and presentation, formulating a management plan, clinical care, patient coordination, monitoring unstable patients, and escorting patients. So it kind of fits in with what one might expect. For example, formulating management plan has relatively the lowest score, and we know that formulating a management plan is probably the longest item to become an expert in out of this list of clinical tasks. That's what you get with the years of experience. And so these students, right in their first year of training, we're still gaining that competency. So you'll notice, though, that for each item there are two bars, a gray one and a blue one. We asked physicians who were not working with PAs the same questions, but we asked them to answer those questions in the context of how helpful do you think a PA should be in each of these items. And what was really interesting was that they answered almost exactly the same levels for each of the items. Give or take a few tenths of a point, they were nearly identical. We actually ran a statistical analysis that showed that there was no statistically significant differences. It kind of validates what we saw the doctors working with PAs reported. So to us, it shows that the PAs are meeting expectations, right? If doctors not working with PAs expect PAs should be helpful at a certain level, and then we see the doctors who are working PAs report that they are helping at that level, it validates what we're measuring and shows that the PAs are doing what they are expected to be doing. So that was something really interesting to find out. We asked the same doctors in an open-ended fashion to please tell us what additional tasks they thought PAs should do that they are not currently doing. Now remember, there's a lot of variability between emergency departments, so what PAs are doing in one place might not be what they're doing in another, but these were open-ended questions. The docs could have written in anything they wanted, and by and far, the number one item that came out, the number one theme was they want the PAs to be ordering, administering routine medications. And of course, this is controversial because medication ordering and medication prescribing in general is sort of the golden egg of doctor tasks that is sort of protected as much as possible in many different countries. But here they said that they wanted the PAs to be doing it. Now, it's important to note the difference, though, between ordering medications in the ED for ED treatment versus having full prescriptive authorities with a prescription pad with your name on it or a stamp that allows you to prescribe anything to anyone at any time. We did not think the doctors were talking about that. We thought they were talking more about the former than the latter. And, it was more about allowing the PAs to, order a bronchodilator if someone's having an asthma attack, or go ahead and give that nitroglycerin, go ahead and start the amoxicillin if it's needed. But it was really surprising and enlightening to see that, the doctors felt that way. And anecdotally, from speaking with ED physicians, a lot of them told me, listen, the PA knows what to do, so why do they need to come and ask me all the time? It's wasting my time, it's wasting their time, it's delaying the treatment for the patient. Rather than them coming and asking me for a signature or prescription all the time, they should just be able to give the order themselves. So if you sum up the top 3 items that the doctors wanted PAs to be able to do, it was ordering medication, starting intravenous fluid therapy, and wound suturing. That was about 60% of the responses. And several other items came in here, like casting, central line, discharge. Again, in a lot of hospitals, PAs are already doing that, but those were the common themes. So we asked the doctors who weren't working with PAs if they would like to, and a large majority, 85% of emergency department doctors who were not working with PAs said that they would want to in the future. And when we asked them why, again in an open-ended fashion, basically half of them said in a broad way that they thought it would reduce their workload, their burden, and would be just generally broadly helpful to the everyday tasks of the ED. Some of them gave some specific items you can see below in the graph, using PAs to do procedures, administrative work, resuscitation, monitoring, and transport. Those are the things that come to mind when doctors think about how PAs could be helpful. We recently finished a large survey of the Israeli population, and we got over 7,000 Israelis to respond to an electronic survey this past year that basically asked them a series of urgent care scenarios, not a series, one of 3 different urgent care scenarios, such as an ankle sprain, a arm laceration that requires stitches, or a child falling off a swing and hitting their head up. And we offered them 2 options. We said, okay, let's say you're confronted with one of these medical scenarios, and you show up to the emergency room, and you're told you can see the PA within 30 minutes or an hour, or you can wait 4 hours for the doctor. Which do you prefer? And overwhelmingly, people chose to see the PA. It was 92% were willing to be seen by the PA if it would save them time. Now, this is a study that we've replicated from several other countries. It was performed in 4 countries in the past: Canada, Ireland, the Netherlands, and Australia. And they got the same results in all of those countries as well. They're reaching over 90% of respondents who say that they would be willing to see the PA if it will save them time. So this was really important because it gave us sort of that 360-degree viewpoint, right? It's nice to know, to survey the PAs and see if they're satisfied with their role. It's nice to survey the people they work with, like the doctors, to see if the doctors are satisfied with them. But none of the observational studies we do could compensate for the patient perspective, if patients did not want to be treated by a PA, if the population, for whatever cultural, societal reasons, said we don't want PAs, then there is no observational research that could override that. And so this was a really important piece of the pie, um, to understand that, okay, that's not the situation in Israel. Israelis are actually very open to being treated by this novel healthcare provider, and if they can see value in it, okay, if you can offer them something like time saving, they are open to it. And so this is another study we're trying to get published right now. The manuscript is in preparation. So some discussion points. The mantra of global PA development is adapt, not adopt. It's virtually impossible to take any singular PA model and implement it fully in a different country, no matter how good that PA model appears to be. Every country has its own uh, system and its own picadillos. And so every country needs to adapt. But there are similarity points. So just to point out a few, the Netherlands also has a learn as you work model where a PA must be hired by a clinic first, and only then they can register for their course. They're paid for their studies from day one, and they work most of the time in the ED with 1 day a week in the classroom. So Israel adapted that piece. The Netherlands, though, do confer a master's degree, and they do provide general medicine education, as opposed to what the PA pilot project is now in Israel. Ireland also had significant struggles with emergency medicine services with very long wait times, and it also was one of the reasons for developing PAs in Ireland. India, the parallel with India is that it all started in one specialty. Indian PAs started in the specialty of cardiovascular surgery. They were only surgery PAs. And as a grassroots model that grew over time and expanded to other specialties, and now are expanding to primary care. But it took a long time, and it was a bottom-up approach. Israel also started with one specialty, mostly, like I said, for political reasons. That's where it could start. And the goal, the vision, is for it to grow from the bottom up with a grassroots approach and expand to other specialties as the PAs start to organize and advocate for themselves and gain some leverage. And in the USA, medics were used to gain political traction as well. The first group of American PAs were medics from the Vietnam War, as most people know. But one of the reasons for that was actually strategic, to gain political traction and get buy-in for this concept of a new healthcare provider. Something to keep in mind about the Israeli project is that these good outcomes we're seeing early on, this, for example, doctor survey that showed helpfulness even as the PAs were still in their education year, it's probably a good fit. It's probably due to the good fit between paramedics and emergency medicine. And that's something to keep in mind as the PA project is developed further. If we develop PAs in family medicine or internal medicine or pediatrics, we probably would not see that early productivity, that early benefit. It will probably take a little longer to reach that. I talked already about this validation that occurred where the PA students were meeting the expectations of the ED doctors. And that really speaks to the theory behind the PA physician dyad. That relationship was coined in the 1970s by medical sociologists to be a mutually negotiated autonomy, right? As the relationship grows, as the trust grows, and as the competencies grow, the physician delegates more things to the PA. And so we see here that physicians really seem to have a pretty good idea of what they could delegate to PAs, and PAs seem to be meeting those expectations pretty well. Ordering medication, surprisingly, was the most commonly cited task desired by the MDs for the PAs to take on. Again, difference though between ED orders versus full prescribing. And our latest research has told us that the Israeli public is open to seeing PAs if they can see value in that encounter, like a time saving. So what are the future directions for the Israeli PA? What does the future hold? Well, the Ministry of Health has convened 2 committees recently to evaluate the future of PAs and discuss how to move things forward. Largely, the PA pilot is considered to be a success, despite some of the early political opposition. It is going in line with the Ministry of Health's grand vision. And so now we are discussing if and how to move things forward into a more generalist model. There's an understanding that things will have to change. The model will need to evolve. For example, this will have to be transferred to an academic institution or multiple academic institutions to provide a more generalist education. It should be education at the master's degree level, and that is one of the main projects that I'm working on at my university. It's taking a very long time. There's a lot of bureaucracy to start a new education program, but hopefully, I'm optimistic we'll get there. And we talked about the unclear role definition. I'll talk a little bit about the PA conference that we put together in April of this year 2019. Sometimes when bureaucracy is stuck and you don't have control over things, you have to take a step back and say, well, what can I do? And this was the approach I took with one of my PA colleagues. We said, well, we can't force the Ministry of Health to change regulations. We can't force the Ministry of Education to approve educational programs, but we can put together a conference. And so that's what we did. I think it was a success. We had more people than we anticipated. We thought it would be a handful of like-minded souls sitting around a table, debating and discussing what to do about this PA project. But it turns out when we started spreading the word, there was really a lot of interest. So instead of 75 people, we had 150. And we were able to get policy leaders, Ministry of Health representatives, health fund leaders, hospital leaders come and discuss and talk about PAs. And it really garnered some support, I think, that maybe wasn't there before, and generated some momentum to move forward. The latest Ministry of Health committee kind of came about on the heels of this conference. So hopefully things will continue to evolve. So thank you very much. I will show you a few pictures here. This was the program for our conference, and pictures from our conference. This guy's me. You can tell it's me because I'm the only American wearing a suit. Israelis are not very formal in general, and so I always stand out. And this gentleman next to me is my PA associate. He's a PA from the first class of PAs, and he works at Sheba Medical Center in Tel HaShomer. This gentleman on the far right is the course director for the PA course at the Ministry of Health, and he is also the main Ministry of Health spokesperson for PAs. And this woman next to me is the chair of my Department of Health Systems Management who recruited me to Israel to work on this project and try to build PAs. Here, for those who recognize her, this is Professor Ruth Bolwick, a well-renowned PA scholar, a longtime director of the MEDEX PA program, now retired from MEDEX, but works as the international liaison for the NCCPA. And she is probably the person with the most global FaceTime experience with PA development around the world. And she was really a huge help to our project, and was kind enough to come to Israel and give the keynote address at our conference. So again, thank you very much. Shalom from Israel. I appreciate the opportunity to tell you a little bit of the story of PA development. I think the future has good things in store for Israeli PAs. Things never go as fast as you want them to, but things are moving forward in the right direction. So I hope to stay in touch and continue to give you good updates. And our conference will hopefully be an annual event. We are starting to plan the next conference in April of 2020. So anyone interested can mark your calendars for April 2020. I don't have an exact date yet, but I'll keep you posted. Thank you very much.
Dr. Berkowitz, thank you so much for presenting. If you have a few minutes, we will open the floor to any questions.
Sure, happy to answer any questions.
Dr. Berkowitz, this is Sharon. I'm currently a first-year PA student through Yale University's online program. Thank you so much for this presentation. It was super interesting, and just to see how you've developed this, bringing the PA profession to Israel and developed a program. That's been really, really cool. I saw that the median age currently for your PA students was about 40 in the PA profession in general. Do you anticipate that going down closer to like 30, 35? And I was also wondering how you guys were hoping to maybe recruit more female PA students in the future.
Sure, great questions. Thank you, Sharon. So I do think that the age will get younger as time goes on. They had a requirement in mind of mandating at least 5 years of experience. So just by virtue of that, the types of paramedics joining were a lot older. I mentioned earlier that research showed that 90% of paramedics in Israel leave the profession within 5 years. So if you're going to get any paramedics that have been doing it for more than 5 years, you're automatically drawing from a pool of much older people who have decided to stick with it for that long. And they're already being a little more lax. I think this year they're taking people with 3 years of experience, which will open up the doors to a lot more younger people. I think that the trailblazer pioneers just happen to be this more seasoned group. Again, the pool of paramedics is skewed towards males, but we've thought about a couple of strategies to make this more attractive to females and to make females candidates feel more included in general. I got some fantastic advice from Ruth Bolwick, who I pointed out here. She said you need to bring them on the committees. You need to bring them on the task force and task forces that we put together. You need to bring them on the professional society boards. And so we made a conscious effort to utilize the female PAs that are working now on our task forces, on our committees, and to bring a more diverse set of faces to the table. And I think that will hopefully open up the attractiveness of this profession to a wider group.
Awesome, thank you.
Yeah.
Hi, Oren, it's Lindsay. I just wanted to say thanks so much for mentioning the fact that every country kind of needs a different model to fit their needs. I think that's a super important plug as we continue to move forward, because it is, like you said, we just can't copy and paste every model into every country. Though, as you know, PAs continue to develop and expand in other countries, I'm sure more generalized medicine models will be followed in the future. But I thought that was a super important note to make. So thank you for that.
Oh, yes, sure, by all means. It's funny because as PA scholars, um, we've been trying to come up with some sort of a global definition of PAs, and that's actually been really hard because, in every country, it kind of looks a little different because of this adaptation process. And that's okay at the end of the day. If it takes us a little longer to come up with a global definition, that's not so bad. Researchers and scholars always want to find a nice little niche to a little box to put people in so that they can be studied. But but sometimes that doesn't work, and so I think it's really important to keep an open mind because a lot of the earlier PA leaders involved in global development had sort of I don't know, more of a narrow view. If you read some things from the past or listen to things that have been said in the past, there was kind of this outlook of, well, if it's not an American PA, then it's not a PA. If it's not based on the American model, then it's not PA, it's something else. And I don't really agree with that. I think that, the definition of PA is probably a lot broader, a lot broader than that, and more along the lines of, somebody who's not a doctor doing doctor-like things, which was one of the original definitions of PAs from back in the 70s. It's probably closer to that, I would say.
What was one challenge that you maybe faced because you've co-founded that program in Boston and you've also created the program in Israel? Was there a challenge that you faced in either of those programs creating that that you didn't expect?
How many hours of CMU would you guys like? Wow, because I could talk about that for a while. Yes, lots of unanticipated challenges. That's part of the fun of building something new, I guess. But I will tell you that if I had to categorize the most significant unanticipated challenges into one category, I would call that category cultural change. Um, and 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 I say that both with regards to Boston University and Israel, because um, Boston University, for example, was one of the first medical schools in the country. Uh, they had an old guard, an old system set in their ways. BU is could be thought of as one of the last places to innovate. But they actually did have some forward-thinking people, some forward-thinking leaders that were interested in innovating. And when they brought us on to start the PA program, that was the hardest thing to do, though, was to convince the people who were ingrained in this system that something new would be okay, and that these PAs would be would add value and not take away from what you were doing, and that these PAs could bring new resources and not just take away the resources you already had. And so convincing people about PAs, every day meeting someone new and explaining what a PA was. In Boston, uh, we had to explain what a PA was almost every day to somebody new. But doing that and doing it with a smile and doing it with open-mindedness and not taking offense to every comment that might sound a little backwards or ignorant, but trying to just educate people and explain is one of the biggest challenges. And in Israel, the cultural change is definitely the biggest challenge. Here, there's no comparison. This is brand new for Israeli society. The healthcare system was always very conservative. It was the doctor-nurse care, and that was it. And everybody was treated by a doctor and a nurse. And allied health professionals are fairly new to the system. Those who existed never had a high status, be it licensure, education requirements. It was always just the doctor or the doctor and the nurse. And so introducing a new player has been the biggest difficulty. When I talked to some nurses about this, who were hesitant, I said, look, I get it, okay? You are protective of your patients. They're your patients, right? And you're used to treating your patients alongside a doctor. And now there's this new family member that's coming in and wants to take care of your patient. And your immediate gut reaction is, no, this is my patient. Who are you? Get away. I'm protecting my patient. But you have to understand that there's a new family member who's come in and who wants to help and who can help. And so let's figure out a way for people to work together for the patient, rather than automatically think that they're just going to step on your toes. So, if I had to sum it up, I would say that cultural change, changing the culture, changing the way people look at a new healthcare provider has been the biggest challenge.
Great, thank you so much. I think that's all for our time today. Thank you, Dr. Berkowitz, for sharing your information and insights with us on the Israeli PA system. We appreciate your time. For any additional information, please see our website at www.pasforglobalhealth.com. And everyone have a nice day. Thank you.
Thank you very much. Have a great day.